discussing about retroperitoneal masses and a little bit about the retroperitoneal anatomy. So talking about the retroperitoneal anatomy first, it's a complex potential space containing multiple vital structures and also known as the extraperitoneal compartment, and it lies between diaphragm and the subperitoneal pelvic space. It comprises of facial layers, spaces and interfacial planes as well as the bridging septa. So this space is further divided into three compartments by anterior renal fascia and the posterior renal fascia. These are anterior pararenal space, posterior pararenal space, and in between is the perirenal space. Talking about the anterior pararenal space, it's bounded by the posterior parietal peritoneum anteriorly and posteriorly by the anterior renal fascia, that is the Girota's fascia. Laterally it is bounded by the lateroconal fascia. Its contents are duodenum, pancreas, ascending colon and descending colon, and root of mesentery. Now the perirenal space is the largest retroperitoneal space, and it's inverted cone shape, base lying over the diaphragm and apex is made by the pelvic inlet. It's bounded by anterior renal fascia anteriorly and posterior renal fascia, that is the jugular fascia posterior. Contents are kidney, suprarenal glands or adrenals, renal hilar vessels and ureters. Posterior pararenal space is bounded by posterior renal fascia, that is jugular fascia anteriorly, and posteriorly by the transversalis fascia. It's very limited space and smallest, and contains just fat and few vessels. Now again refocusing on the retroperitoneal anatomy, it's also divided into zones, that is central zone, two lateral zones and the pelvic zone. Zone 1 is central zone, which is superiorly bounded by diaphragm, and inferior boundary is by the sacral promontory. Lateral boundaries are made by the psoas muscles. This extends from aortic hiatus and distally up to the bifurcation of the IVC or the aorta. So contents lying in zone 1 are aorta, vena cava, lymphatic channels, nerve plexus, celiac axis, superior mesenteric artery, proximal renal vessels, pancreas and duodenum. Zone 2 is the lateral retroperitoneal zone, and it extends from kidneys to the parabolic udders, and content being the kidney, renal vessels, ureters, hepatic splenic flexures. Zone 3 is pelvic retroperitoneal zone, and this is bounded anterior by the retropubic space and posteriorly by the sacrum. Contents being rectum, bladder, uterus, cervix, iliac vessels and the branches. Also we should know in the retroperitoneum is perivertebral space that contains the sympathetic chain, and this space is further divided into the prevertebral and the paravertebral space. This diagram is thoroughly showing all the spaces that we have discussed and their boundaries along with the structures contained in the spaces. So remember here that primary retroperitoneal masses are those which do not arise from the specific retroperitoneal organ. Secondary lesions are those which arise from the specific retroperitoneal organ, or is the metastatic disease, or is the metastatic retroperitoneal lymphadenopathy. These comes under secondary masses. So talking here about the retroperitoneal disease that is primary origin, there may be neoplastic lesions which may be malignant or benign, and further these primary retroperitoneal masses are classified into solid and cystic. 70 to 80% of the primary retroperitoneal tumors or masses are malignant, and they account for 0.1 to 0.2% of overall malignancy of the body, and these are prevalent in adults as well as they are seen in any age group. Now solid tumors are further divided into four groups. They may be mesodermal or mesenchymal origin, neurogenic tumors, extragonadal germ cell tumors, or lymphoproliferative masses. Cystic tumors can be lymphangioma or cystic mesothelioma, or mature teratoma or epidermoid cyst can be there. Non-neoplastic primary retroperitoneal disease can also be there. That includes primary retroperitoneal fibrosis, non-Langerhans histiocytosis, or extramedullary hematopoiesis. Now talking about the solid masses, mesodermal or the mesenchymal tumors comprise of the 75% of the retroperitoneal masses, and sarcoma out of these is the most common, and that comprise of 1/3 of the retroperitoneal tumors. Out of its subtypes, liposarcoma is most common and comprise of 70%, followed by the leiomyosarcoma, that is 15%. Others may be myxofibrosarcoma, fibrocytoma, lipoma, myelolipoma, or extra gastrointestinal stromal tumors can be there. Now the primary proliferative tumors can be there. That includes Hodgkin lymphoma or Hodgkin lymphoma or other B-cell type of lymphomas. Neurogenic tumors may be malignant in nature or benign in nature. These may include neuroblastoma, neuroendocrine tumors, or benign tumors like schwannomas, neurofibromas, gliomas, paragangliomas. Those may be functional and non-functional type. Extragonadal germ cell tumor may be mature, immature, teratoma, or mixed type. Liposarcoma can be well differentiated, dedifferentiated, round cell, or myxoid or pleomorphic type, and out of this well differentiated type is the most common one. Neurogenic tumor may be neural sheath tumors, or these may be arising from the sympathetic ganglia, or paragangliomas can be there. Neural sheath tumors include schwannomas, neurofibromatosis, neurofibroma, neuroleiomyoma, or malignant nerve sheath tumors. Tumors getting origin from sympathetic ganglia include ganglioneuromas, neuroblastomas, or ganglioneuroblastomas, and these are commonly seen in pediatric age group also. Paragangliomas or 40% malignant, and reteroperitoneum is most common extradural location for these tumors. Out of this, organ of Zucker is most common, that is located in the para-aortic region near the origin of inferior mesenteric artery. Extragonadal germ cell tumors can be mature or immature as discussed previously, and markers used for specific markers used for these tumors are CEA, CA99, AFP, and beta HCG can be done. Clinical symptoms of these retroperitoneal masses vary, and there may be no or non-specific symptom for quite long time, and until these tumors attain the substantial size, then the clinical symptoms appear in the later stage. Symptoms vary depending upon the location of the lesion, relation of the adjacent structure, and clinical behavior of the disease itself. There may be palpable mass, abdominal distension, early satiety, loss of weight, abdominal discomfort in general, and vague pain can be there. Gastrointestinal or urinary tract specific symptoms can be there, which are often because of the displacement and the pressure effect on the tract. Hypertension, fever, and systemic signs can be also seen in patients of neuroendocrine tumors or other tumors like neuroblastomas. For diagnosis of this patient, blood investigation can be done along with tumor marker, and urinary analysis can be assisted by urinary catecholamine or the metabolites in case of neuroendocrine tumors. Ultrasonography, X-ray, CT scan, or MRI can be done in these patients, and these retroperitoneal masses represents a challenge due to the overlapping image findings. Localization, characterization of the disease, size of the lesion, vascular involvement, extent of local invasion, involvement of adjacent organs, and assessment of the metastasis can be done. Important tumor characteristics, growth pattern, and the vascularity of the lesion can be seen. That helps in the narrowing of the differential diagnosis. For categorization as a primary retroperitoneal lesion, remember that we should we should rule out any origin from the larger retroperitoneal organ. On imaging, whether the tumor is solid, cystic, macroscopic fat, calcification, myxoid stroma, necrosis, and area of vascularization should be properly assessed. Relationship of the adjacent structure and the invasion or spread or the pressure effects should be seen. MIBG scintigraphy or FDG PET CT or dotate PET CT can be done in case of metastatic disease, whether it is primary or secondary origin. Definitely diagnosis can be established by histopathological analysis by using FNAC or two-cut biopsy, which can be assisted by CCT or USG guided. Management of these patients should be disease specific. Benign mass or tumor, if we encounter, can directly be taken for surgery, or in case we encounter the malignant disease, neoadjuvant chemotherapy may be required for downgrading the tumor, followed by surgery, and the post-op chemotherapy or radiotherapy can be added on. Corticosteroid immunotherapy or tamoxifen can be used in primary retroperitoneal fibrosis cases and other primary retroperitoneal diseases. Treatment of the underlying disease should be focused in case of secondary lesions in the retroperitoneum because of a known or unknown metastatic disease. This was a general preview of retroperitoneal masses and retroperitoneal anatomy. I hope this video was helpful for the viewers. Thank you.